this webinar is the first in a series of professional education series that the National Patient Advocate Foundation, in affiliation with the Association of Community Cancer Centers, the Oncology Nursing Society, Community Oncology Alliance, and the Center to Advance Palliative Care, are putting together to look at to address critical issues in providing value-based, person-centered care. So that is me. I'm Gwen Darian. I'm the Executive Vice President of Patient Advocacy for National Patient Advocate Foundation and Patient Advocate Foundation, and I am thrilled to be introducing this first of our webinar series. This is something that is a very, very great concern to me and to my fellow survivors of serious illness. I'm a two-time cancer survivor, and one of the things that I have found over the years, my first cancer was over 20 years ago, is that while there is always the intention to treat the whole person, we don't always have that effect. And I think that one of the things that is so critical about what you're going to be hearing from our guest, Dr. Diane Meyer, is how to treat the whole person and how to integrate that treatment of the whole person into everything that happens along people's encounters with the healthcare system, and to help ensure that the gaps in care are closed, and help ensure that what people value and what is important to them and where their preferences are really brought into front and center into the conversations and the decisions that people are making in whatever way that they want to make them. So I would also like to say that this is a project that's being hosted through our Project Innovation platform. And while the series today is primarily for professional education, we do have a number of our patient advocate partners on the call, and I'd just like to welcome them, and also welcome them and reinforce the idea that patient understanding and input is critical to this landscape and to forwarding this landscape. It is essential to our success, and particularly now in the uncertain time of what's going to happen with healthcare reform, it is more important than ever that patient preferences and values be put to the front and center. So I'd like to begin with an opening poll that will give us a chance to understand who is on the phone and who's on their computer looking at and participating in this webinar. So my colleague Peterson Jamunge has opened the quick poll, and the poll is in progress. So we're leaving the poll open for 15 seconds so you can select one of the following that best describes your oncology practice. So just click on the poll and then click on your choice. Okay, so as we look at the results from our poll, I think what's quite interesting is that the highest number of people, 41% of you, have said that you actively plan to strengthen relationships with palliative care specialists, and 27% say that you're considering palliative care options. So I think that this webinar should give you a very good roadmap to ways to integrate palliative care and integrate person-centered care into your practices. And for our patient advocate partners, it should give everybody a very good sense of where the landscape, how the landscape it looks from our professional partners' point of view. So I would like to, first of all, tell everybody that this webinar is being recorded, and we will put it up on the website, and you'll be able to access it after the recording, and that we will also reserve time at the end of the presentation for Q&A. So we will unmute the lines, but you may also there's a on the side there's a chat function. You may also ask a question to the organizers and panelists. So thank you all for your response. Thank you for taking this poll, and thank you for being on this webinar. I would like to now introduce Diane Meyer. And for those of you who do not know Dr. Diane Meyer, she is the director of the Center to Advance Palliative Care, which is a national organization devoted to increasing access to quality palliative care for the seriously ill and their families in the United States. So one of the things that's remarkable is that under her leadership, the number of palliative care programs in the U.S. hospitals has more than tripled in the last 10 years. She is co-director of the Patty and J. Baker National Palliative Care Center, vice chair for public policy and professor of geriatrics and palliative medicine, Catherine Gaisman professor of medical ethics, and she was the founder and director of the Hertzberg Palliative Care Institute all at the Icahn School of Medicine in Mount Sinai in New York City. She has received a MacArthur Foundation Fellowship. She's was named as one of 20 people who make healthcare better in the U.S. by Health Leaders Media in 2010. Dr. Meyer has over 200 peer-reviewed publications in medical literature, and her most recent book, Meeting the Needs of Older Adults with Serious Illness, Challenges and Opportunities in the Age of Health Reform, it was published by Humana in 2014. So we are thrilled to have Diane Meyer with us and thank her very much for agreeing to lead this really very timely and important webinar and to kick off our series. So thank you.
Thank you so much, Gwen. It's an honor to be invited, and thanks for that very kind introduction. I want to begin with this graphic showing what I'm sure everybody knows at some level, which is the enormous differential in per person spending in the United States as compared to other developed nations. And as you can see here, the amount of money that we spend per person, particularly as we start to get over age 55 or so, absolutely dwarfs the spending in other developed nations. And what's interesting about that is not only do we spend many, many times more dollars on healthcare per person, we actually rank 40th in quality standards compared to other developed nations. So what that spending is getting us, for certain subsets of our population, it's getting good care. For many other subsets of our population, our quality metrics look like those of third world countries. So this slide basically shows what the price to our society is of the continued exponential growth in healthcare spending, because it actually is a zero-sum game. So these are data from the state of Massachusetts, but every other state has similar data that shows on the left-hand side the increasing cost to states of covering healthcare, and that's not only state employees, it's very much Medicaid, the state Medicaid budget. And the consequence of that, and this is between 2001 and 2011, and obviously the increases have continued since then, but the consequences are that the budget has to be balanced at the state level. States cannot do deficit spending. So they're cutting in virtually every other area of state spending. And I find this particularly disturbing to look at the cuts in education, in public safety, in infrastructure, things like bridges, roads, housing, human services. So there are real consequences to the health of our society as a whole, the continued, pretty much unfettered growth in healthcare spending in the United States. And of course, those of you working in cancer see this up close and personal every day in the efforts of your patients to get the health care that they need. So what this slide shows is that the average insured cancer patient pays roughly $5,000 out of pocket per year. And with the new biologic agents, that number has continued to increase. The share of premiums that we as employees pay for our health plan coverage has increased nearly 200% in the last 15 years or so. About half of Medicare beneficiaries with cancer spend more than 1 out of 10 of all of their dollars on their out-of-pocket health care costs, and more than a quarter spend more than 20% of their resources on out-of-pocket health care costs. And that has real consequences. So while serious illness is the #1 cause of personal bankruptcy in the United States, cancer patients are 2.6 times more likely than others with serious illness to be bankrupted by their disease. And those who have the highest co-payments, $53 or more, were 70% more likely to discontinue treatment And of course, what that leads to is either incomplete treatments or premature cessation of treatment. And thus, when cost sharing becomes toxic, patients space out chemo, delay care, decline diagnostic procedures, and replace prescription drugs with over-the-counter, and or they replace food with their medical care. This is a study from 2 weeks ago in cancer that found that 1 in 3 non-elderly, non-Medicare cancer patients are not taking their prescribed regimens because they simply cannot afford it. So I would call this a crisis in the oncology space. And so, of course, no surprise, there are some policy efforts to try to address this issue. Fueled by the high cost of health care, the demand for value-based care, that is, care that is reimbursed based on value, quality, and cost, as opposed to fee-for-service, has grown. And by last year, or 2 years ago, more than 1/3 of all health care payments in the U.S. were value-based, a process that continued to grow last year. And the providers on the phone, nurse practitioners, PAs, and physicians, should be aware that under macro, which replaced the sustainable growth rate influencing how doctors and other providers are reimbursed, as of very soon, as of this year, our reimbursement from Medicare will be directly tied to how we perform on quality measures, as well as other activities, and how we control spending, up to a total of basically 18% of total payments at risk. So you can, if you adhere to the quality and cost guidelines, you can gain 9% in reimbursement. If you don't, you can lose 9% from your baseline. So it's really about 1/5 of your total reimbursement that's at risk under macro. So one of the ways in which oncology practices can address this radical change in how we are being paid and measured is the oncology care model. And what that tries to do is create financial and quality performance accountability based on an episode of chemotherapy administration. And this is not only Medicare, it is 17 other commercial payers who are also participating in the oncology care model. And those practices that are eligible to participate have to provide better care coordination, navigation, and must demonstrate adherence to national treatment guidelines. Under the oncology care model, there's 2 options to incentivize quality and enhance services. One is the per beneficiary monthly enhanced oncology services payment, which is $160 per patient per month during the chemotherapy episode, which is to help practices invest in things like 24/7 telephone coverage, invest in navigators, invest in care managers, people who can help patients get their needs met that may go beyond which chemotherapy to take, including their financial needs. Participants in the oncology care model can also take on risk and get additional payment by participating in a performance-based incentive payment and demonstrating reductions in the total cost of the oncology care, as well as improved quality. And the advantage of participating in that second type of payment, that is accepting some downside risk, is that in 2018, those participating in the oncology care model with downside risk will get an automatic 5% payment bonus as well. So what are the requirements to be in an oncology care model practice? These practices have to provide patient navigation, which they have to provide, present a care plan that includes 13 components that were identified in the IOM report of a few years ago called Delivering High Quality Cancer Care, Charting a New Course for a System in Crisis. And there were 13 components recommended by that IOM committee. among which is patient access 24 hours a day, 7 days a week, to a clinician who could do something like tell a person what to do if they were in a pain crisis, or if they hadn't had a bowel movement in 3 days, or if they were feeling short of breath. And that clinician, so this can't just be a distant care manager, it has to be a clinician who has access to the electronic health record and can make a recommendation short of sending that person to the ER based on what they see in the medical record. And the therapies, the chemotherapies and cancer treatments have to be consistent with nationally recognized clinical guidelines. Practices have to use data to do quality improvement and use certified EHRs. So the quality measures that affect payment, and there are 12 here, and these, the most current version of this can be found on the OCM website. But look at the first 6 measures here, and they include all-cause hospitalizations during the 6-month episode, all ED visits that did not result in a hospitalization, the proportion of patients who were admitted to hospice for at least 3 days, pain quantification and plan of care for pain, screening and following up on depression, and a CMS-developed patient-reported experience measure. So the reason I highlighted these 6 measures is because all of them have demonstrated to be improved when palliative care is delivered at the same time as cancer care. I'm not going to spend a lot of time on this, but suffice it to say that an OCM participant can decline to accept downside risk for a short period of time. If you choose that option, you have to qualify for performance-based payment in quality and cost by the middle of 2019. If you take two-sided risk, where you're accepting the possibility of losses, that option begins next year in 2018, and the level of the Medicare discounting on your payment is lower. Right now, there are about 190 cancer centers that signed up to participate in the oncology care model, and 17 payers as well as CMS participating. So success in these models, and whether or not you're in the oncology care model, your oncologists, your nurse practitioners, and your PAs are subject to MACRA. Everyone is. So the obligation to improve both in terms of quality and cost covers pretty much everybody, whether you're participating in the oncology care model or not. And that requires attention to the patient experience and attention to unnecessary and preventable health services utilization. So that includes preventing unnecessary ED visits and hospitalizations, increasing appropriate referral to hospice and with appropriate length of stay, and keeping costs below the target. So what is palliative care? It is a team-based medical approach focused on maximizing quality of life by providing relief from symptoms and stresses. And by stresses, I include things like social stresses like poverty or illiteracy or unsafe housing or food insecurity or concurrent mental illness, substance use disorder, etc. Palliative care is appropriate at any age and any stage of a serious illness, including cancer, and as you know, can and should be provided along with curative treatment as an added layer of support. And what we have here is one of a series of ads from the American Cancer Society that you may have seen on the Washington Post website or the New York Times website that basically is marketing directly to the public and says palliative care sees the person beyond the cancer treatment. It gives the patient control, bringing trained specialists together with doctors and nurses in a team-based approach to manage pain and other symptoms, explain options, and improve quality of life. And cancer is actually way ahead of the game in terms of research on the impact of concurrent palliative care along with best cancer care. Other serious illnesses in this country like heart failure, COPD, are way behind the oncology community in driving the data. And this study, which I'm sure you've all seen from Jen Temmel at Mass General, published in the New England Journal of Medicine, actually 7 years now, was a randomized controlled trial of newly diagnosed lung cancer patients randomly assigned to best cancer care, Mass General lung cancer care. And the intervention group got that best cancer care plus concurrent palliative care in the cancer center, in the outpatient center. They found a dramatic reduction in depression, very significant increase in quality of life, and a nearly 3-month gain in survival, probably related to less hospitalization towards the end of life, less toxic treatments towards the end of life, and better management of symptoms and better sense of confidence and control for the patient and the family. This is a study from a couple years ago looking at the implications of waiting for palliative care consultation at a comprehensive cancer center. So what often happens, at least in my hospital, is that palliative care gets involved when the patient is actively dying, when they are no longer able to get out of bed, when their breathing becomes rapid, when it becomes perfectly obvious to everyone that they're at the very end of their life with a few days to live. The difference in impact of palliative care when it's introduced early versus late is very substantial, and you can see here in this study that hospitalizations were 33% versus 66% with early palliative care, ED visits 34% versus 54%, and ICU use down to 5% versus 20%. So if an oncologist or an oncology practice is going to be at risk for the total cost of care for that patient during that chemotherapy episode, if you're going to get palliative care involved, you will see by far the greatest impact on unnecessary spending if you get palliative care involved early. And what that does essentially is shift the expenditures from inpatient to the community setting, outpatient and hospice, with savings of about $2,500 per cancer patient. So here's a case study example. This is a patient that we took care of at Mount Sinai. His name is Bernard. He had stage 3 pancreatic cancer with really severe pain that would come and go and was very difficult to manage by the oncology practice. His overwhelmed and exhausted wife called 911. This is the 4th hospitalization for a pain crisis. On the 4th hospitalization, the palliative care team was called, put him on a standing opioid regimen, both long-acting and short-acting for rescues, and a very aggressive bowel regimen, and added Meals on Wheels and some respite care for his wife. What she said to the oncologist is, "It's the first time I've seen him smile for months," and 15 months later, he has not once been back to the ED or the hospital. So I think the point to be made there is that symptom crises and family caregiver exhaustion are the proximal causes of 911 calls and ED visits and hospitalizations, and they are preventable with the appropriate palliative care plan in a prospective and preventive manner. So how does the oncology team provide early access to palliative care? And it's really based on a relationship between the oncology team and the palliative care team. I find that many of my colleagues in oncology are hesitant to involve palliative care early because they're afraid that patients will lose hope or be afraid. Yet when we did a public opinion poll in 2011 and defined palliative care the way I defined it for you earlier in this talk, as a team that works alongside your regular doctors to focus on maximizing quality of life for you and your family by addressing pain, symptoms, and stresses, that the overwhelming majority of people and their families wanted access to that kind of care. So it's really important that it is described by what it is. And I think sometimes we physicians, not having trained many of us in an era when there was palliative care available, need to learn that it is helping people have the best possible quality of life, and in fact very likely to help them live longer. Because when described that way, everybody wants it. ASCO, as people know, put out a clinical practice guideline in 2016 that says inpatients and outpatients with advanced cancer should receive dedicated palliative care early in the disease course at the same time as active treatment. Referral to palliative care teams is optimal, and services may complement existing programs. Providers may refer family and friend caregivers of patients with either early or advanced cancer to palliative care services. And again, the point here is that the patient's likelihood of avoiding unnecessary ED visits, 911 calls, and hospitalization depends critically on the preparation and support of the family caregiver. So the ASCO statement provides guidance on defining high-quality palliative care. Clearly, most palliative care for most patients is delivered by the oncology team that assesses and manages symptoms, talks about what to expect with this disease and the treatment options, asks people about what's most important to them, and reviews treatment options to help achieve those goals. When it's important to have access to palliative care specialists to work with you as consultants are when there are complex or intractable symptoms, when there are combined social and behavioral challenges for the patient and the family, to help patients and families clarify realistic priorities for care, and to support caregivers and to maximize quality of life, with hospice referral occurring when active cancer treatment is either no longer effective, not working, or its burdens are exceeding its benefits for the patient in question. So easier said than done. I'm a baby boomer doctor, and I know that when I went to medical school and did residency and fellowship, there was no such thing as palliative care. And really until 10 or 15 years ago, there wasn't. So most of us who trained more than 10 or 15 years ago really didn't get exposure to these skill sets or this knowledge base. Yet, oncology teams within the OCM have to conduct expert and effective pain and symptom management. And as I said before, symptom crisis is the #1 reason for 911 calls in cancer patients. Must be able to conduct skilled communication about achievable and affordable priority for care and manage coordination of that patient's care, not just when they're in the cancer center, not just when they're in the hospital, but also when they're at home. And while this seems obvious and logical, it's really hard to do if you haven't had any training in how to get this done. So in response to that gap, the fact that most clinicians out there really didn't get this in school or residency, my organization developed a whole online training curriculum for the core knowledge and skills that every clinician who takes care of seriously ill people, especially oncologists and oncology team members, should have. We have a set of courses. These are all CME and CEU linked courses. They're about 20 to 30 minutes long. They're all online. You can do them on your phone, on your iPad, or on your computer, that basically help people gain some scripting and some approaches to what are very challenging conversations for clinicians. Delivering serious news, talking about prognosis in a realistic, honest way, clarifying the patient and family's expectations and hopes, conducting family meetings, and initiating advanced care planning conversations. The reason most of us avoid these is because we don't know how to do them, because it wasn't in our training, and we don't have time because we don't know how to do it. Again, perhaps surprisingly to the public, but not to me as a physician, skilled opioid management was nowhere to be found in my curriculum, and remains absent most of the time in undergraduate and graduate medical and nursing education. Yet we all know that there is a substance use disorder epidemic in this country, and the reason for that is largely because many clinicians are inappropriately prescribing opioids, and really never got the training on how to do it safely and effectively. So we put together a whole curriculum on evidence-based pain management that will support a clinician in, for example, managing pain in someone with a history of alcoholism or a history of substance use disorder who needs pain management but is at very high risk to become addicted. How do you do that safely? How do you do that in a manner that protects you and your practice and in a manner that delivers high quality care? These issues were always there, but addressing them is no longer optional because of the pressure on practices to demonstrate improved quality and reduce cost. We also have a series of courses on other very common distressing symptoms like dyspnea, constipation, nausea, vomiting, anxiety, and depression. We launched this curriculum in 2015. We now have more than 1,000 hospitals and health systems participating and taking these courses. They have been very warmly received, have had very high impact at the centers when they're used. And what we're finding is that when a clinician takes one course, their average total course taken is up to about 6. So they seem to like the courses. They're very Apple-like, they're interactive, they're fun. You can't get from one screen to the next without answering a question. So it's not a boring series of PowerPoints. And as I said, CMEs and CEUs for your nursing staff, social work staff, NP staff, PA staff, and MD staff as well. So, not every patient needs specialty level palliative care. The ones who do are the ones who are starting to show more difficulty with symptoms, more complex decisions, complex families, poor adherence, high caregiver distress, and who are starting to use the emergency room to manage their disease. And I think I want to encourage people to think about palliative medicine like you would think about any other consultant. You're an oncologist, you frequently turn to the infectious diseases consulting team if your patient develops an infection, if a patient has poorly controlled hypertension that hasn't responded to anything we've tried, we call cardiology. Similarly, if your patient has intractable pain, compromised and declining function and caregiver distress, it's equally professionally appropriate to involve your palliative care team in a consultation. Most oncology practices are already in parts of the country or in communities or systems that have palliative care teams there, so it's really a matter of partnering. Increasing numbers of cancer centers are actually embedding palliative care teams within their practice. Mount Sinai now has a full interdisciplinary palliative care team in our cancer center. And this is just a patient that I took care of in concert with an oncologist at a different medical center. He and I worked together to take care of her for over 2 years, non-small cell lung cancer. She lived 6 years after diagnosis of stage 4 disease. In the last 2 years of her life, I worked alongside him to manage her fatigue, her depression, her pain, anxiety, and towards the end, her dyspnea. And only at, I'd say, about 2 months before she died, when her disease was progressing despite maximal therapy, did her oncologist refer her to hospice. So she's a great example. Jenny is a great example of someone who really benefited and had no hospitalizations during the last 2 years of her life because of the partnership between the oncologist and me. Just to make the direct link between the oncology care measure required measures and the threats to an oncology practice and how a palliative care team can mitigate those risks. One example is the first measure is risk-adjusted proportion of all-cause hospitalizations within that 6-month chemotherapy episode. As I said before, symptoms are the main reason for calling 911 and coming to the hospital. And then they get admitted because they're medically complex, because they have cancer. Strong palliative care skills can prevent those symptom crises and associated hospitalizations. And same with the ED visit measure. The proportion of patients who died who were admitted to hospice for more than 3 days, again, concurrent involvement of a palliative care team really helps the transition from a joint quality of life and cancer treatment focus to a quality of life focus, because it's not an abrupt transition. It's a integrated transition. Pain and plan of care for pain, obviously palliative care skills are critical to that. Screening and managing depression. It's one thing to screen for depression, it's another thing to effectively manage it. Many oncology practices have that down to a science, many do not, but that is a critical measure in the OCM reporting. And lastly, patient-reported experience. And study after study after study of palliative care interventions shows marked improvement in both patient and family experience of care when they are supported by palliative care teams. There's also a website for your patients called getpalliativecare.org that not only includes a provider directory. So say you're in New York City and you're managing a patient who lives way out in rural Connecticut, you can help that patient find a palliative care team that they can see in rural Connecticut while you are managing their cancer at your cancer center in New York City. It also helps patients and families understand what palliative care is and how it can benefit them. In order to continuing support you all, we will be setting up 3 virtual office hours. And virtual office hours are just like office hours with your professor at college, where you can get on the phone and ask any question you have. So we limit the number of participants on these office hours so that we can hear what challenges and opportunities you're facing, answer questions, and connect you to resources. And we will send information on registering for these to all of you when this webinar is over. And let me then advertise my friend and colleague, Tony Bach, who started a company called Vital Talk to train first oncologists, but then all clinicians in how to have these conversations that I think most of us find pretty challenging and emotionally stressful. And Tony will do the next webinar in this series titled Sharpening Person-Centered Communication Skills and Strategies. So I'll stop talking now and hope that there are some questions.
Great. Thank you, Diane. Tony Bach's the next webinar will be mid-June, so we'll send you all information about that. But now I'd like to move to the question and answer part of this. I think that Diane gave us tremendous amount of information, and I'm sure that there are lots of questions. There is on your screen on the right where you have the GoToWebinar control panel, there's a place that says question. So you can ask your question there, and I will read it to Diane, and she will answer, and she can answer. So please send in your questions. So Diane, it's Gwen. I have a question to start off. Every time I hear this, it surprises me when I hear that palliative care is a field that's not much more than 10 years old, and that communication, this was not something that you were trained for in medical school. What we all stop thinking about some of the things that we learned if we aren't using them at the last point that we learned them. But it would seem to me that skilled communication is critical to to healthcare providers treating patients in a person-centered way. Can you I don't even know how to ask this question as a patient, but as a patient, you can clearly see the range of skills that healthcare providers bring to the table. What would you suggest that we do, and there are some patient advocacy groups on the telephone to really spur the further expansion of palliative care?
Well, that's a great question, Gwen. And what I try to coach the public, the patients, the families, to say is, first of all, to understand that many of their clinicians had no exposure to palliative care or the skills of palliative medicine during their training. So they didn't get trained in conducting, we didn't get trained in conducting complex conversations. We didn't get trained in really safe and effective pain management. I mean, many oncologists at my hospital do not know, for example, that hydromorphone or Dilaudid is 5 times more potent than morphine,
Wow.
milligram per milligram. They don't know that, yet they're prescribing these drugs. And you can see how patients get in trouble because hydromorphone is very, very potent. So 10 milligrams of morphine equals 2 milligrams of hydromorphone. So if you prescribe 10 milligrams of hydromorphone, your patient is likely to overdose. Right. So those are the sorts of things that amazingly and shockingly didn't get taught. So I guess the message to the consumer, the patient, and the family is that if you're not getting relief, it isn't your doctor's fault, first of all. And second of all, that they may not know, your clinician may not know, that palliative care is something you should be getting at the same time as your regular cancer treatment, because the evidence is very clear that you will feel better, do better, and live longer. So the patient and family may actually need to educate the clinician on this and may need to take some initiative in getting access to these kinds of teams. And that's why we developed this website, getpalliativecare.org, that the public can use to find palliative care resources. In the case of Jenny, who I mentioned to you, Jenny was not getting palliative care at her New York City Cancer Center and kept asking her oncologist questions about what it was going to be like when treatment stopped working. And he kept saying, I have more treatments, we're not there yet. Jenny was a psychologist, and she could tell that it was at least as upsetting to her oncologist as to her that they were going to reach a point when treatment stopped working, and that it was very painful for him to talk about that. So she went online and found me online.
Wow.
Now, very informed and self-managing patient, not everyone is like that. But then he and I worked really well together for over 2 years, mostly communicating by phone and email. But it went really well, worked out really well for Jenny, and I think it helped her avoid symptom crises and unnecessary ED and hospital visits and helped her feel in control. So, you know, this oncologist, by the way, is one of the best oncologists I know. He did give her 6.5 years of life after diagnosis. And he is now hiring 2 palliative care teams to embed within his cancer center. So Jenny was our patient a while ago, but that experience has affected how he is allocating resources for his patients.
And that, you know, that, so the other question then that naturally leads from that is that Jenny was a very activated patient, and many people who find their ways to even to patient advocacy groups are also activated patients. What about, what would you say in terms of what would you say in terms of a patient that doesn't have that doesn't have that kind of those kind of resources or access? How would you encourage their healthcare providers to really take this focus?
Well, again, I think that healthcare providers are always doing the best they can with the knowledge and skills that they have. what's happening is that the pressure to move away from fee-for-service payment and towards payment based on quality and cost, meaning certain outcomes have to be delivered to get paid, and cost has to be controlled in order to get paid. And if neither of those things occur, the clinician will eventually be forced to accept a financial penalty. That is really focusing people's attention in a different way on whole person care, the patient and the family experience, the need to address symptoms safely and effectively, because symptoms drive unnecessary 911 calls, ED visits, and hospitalization. So basically what's happening is that health policy is pushing all of us, all clinicians, not just oncologists, to take these issues very seriously, because the economic survival of our practices will depend on it. But in the meantime, I think it's helpful for, this is a process. It's going to take years to evolve. So if you're a cancer patient right now, what I suggest you do is get to getpalliativecare.org, read about it, and print out the pages that define what it is, and bring that to your cancer center and ask if your clinicians there can refer you to someone if they don't have access to the resources there.
I have some questions on the in our question queue. So one question that just came in, it was, how can one scale palliative care services when there are not enough palliative care specialists? For our system, the demand is outweighing the supply.
Okay, all right. So the short answer is to make sure you are using your palliative care team for things that only they can do. So for example, our palliative care team gets called a lot because the oncologist wants to refer the patient to hospice. It is not necessary to call the palliative care team to refer the patient to hospice. Our palliative care team gets called a lot by house staff. So what we're trying to do is get the NPs and the PAs in our cancer center to take all of the CAPC courses so that they can do basically the frontline palliative care management of the cancer patients, so that the specialist level palliative care team is doing stuff that is too complicated for the frontline team to handle, whether it's pain management in someone with a substance use disorder, or pain management in someone with a coexisting behavioral health problem like depression, or coming to a decision about options for care with a very complex family environment. Use the palliative care team for things only they can do, and try to increase the skill set and capacity of the frontline team, nurses, social workers, nurse practitioners, PAs, and oncologists, to do the 90% of the work that the frontline team, with a little bit of extra training, should be able to take on. I think that's going to be the solution going forward. In the meantime, we're trying to train as many people as we can, as fast as we can, but as the listener pointed out, the supply is nowhere close to meeting the demand of specialist level palliative care. So all of us have to gain skill and ability to meet many, if not all, of these needs ourselves.
We have another question from Erin. She asked, what kind of individuals would be an ideal palliative care team consist of?
Well, there actually are national quality guidelines that address what a high-quality palliative care team consists of, and it consists of, at a minimum, 4 disciplines: physician, somebody with expertise in the complex medical and symptom management interactions in people with very significant serious illness. Nurses, whether nurse practitioners, most teams have nurse practitioners, but many also have RNs. Social work, because of the very strong and significant role of social determinants of health in driving healthcare utilization, like lack of transportation, like the only caregiver works full-time and can't afford to take a day off work to bring her relative into the cancer center, things like that, unsafe housing, food insecurity, and chaplains, because what we find is that the diagnosis of cancer and the experience of living with and being treated for cancer creates enormous spiritual and existential challenges for patients and families. Why did this happen to me? I had so many plans. There was so much that I hoped to be able to do. And chaplains are uniquely positioned and well-trained to go at those meaning and purpose questions, to help people explore the sense of betrayal and unfairness that many patients and families feel after a serious diagnosis like cancer. So I think what's important to note is that not every team has four full or more FTEs. We have palliative care teams in safety net and rural hospitals where there is, for example, a half-time nurse practitioner on the payroll, but that nurse practitioner has reliable connections, for example, to a palliative medicine physician in another city, to social workers in her community, and to a chaplain or multiple chaplains in the community. So you can cobble together the interdisciplinary team by working with the resources that are there. They don't all have to be on the payroll of the palliative care team, as long as you have reliable access to them and know when to involve them in the care of patients. Any other questions, Peterson?
Yes, we have another question. What if the treating oncologist and the palliative care oncologist have different opinions? How can they co-manage the same patient within the same practice?
Well, so my feeling about this is that when the patient belongs to the oncology practice, that the oncologist is the treating physician, and the palliative care team are consultants. And the client of a consulting team is the referring physician. So it requires a lot of skill to work alongside our colleagues when our opinions differ. I find that most of the time opinions differ because of lack of information potentially on both sides. So palliative care teams working in cancer centers really have to get themselves up to speed on many of these new, very high impact treatments that we didn't get trained in when we were in residency because they didn't exist. And understand what benefit the oncologist is hoping for the patient. So it's kind of recognizing that we don't have all the facts on the palliative care side, and then similarly on the oncology side is recognizing that some of the patient's experience, spiritual, physical, social, emotional, that we may not know needs also to be addressed, and that the palliative care team can bring us information and guidance on addressing the whole person experience. So it's about building relationships between the palliative care team and the oncologist, building trust, doing a lot more listening than talking. And I'll tell you a story from the Mount Sinai Cancer Center where, because the oncology patients had a very high rate of 30-day readmissions and hospital mortality, the hospital was willing to invest in supporting an embedded palliative care team in the cancer center as well as on the cancer floors in the hospital, but only if the oncologist agreed to a routine screening of cancer patients for palliative care needs. And so they agreed, the oncologist agreed to do this. They, in partnership with the palliative care team, established the criteria for the screening, like which patients would screen in to receiving palliative care consultation, and they agreed to a 6-month pilot. And at the end of the 6-month pilot, the 30-day readmissions had fallen by 60%, hospital mortality had fallen by about 50%, hospice referral had increased exponentially. But the most important outcome was that the oncologists were now wondering how they had ever managed to practice oncology without their own palliative care team. So this is years later now. That's what the oncologist said. I don't know how we ever practiced oncology without you. So it's really a building of trust and recognizing on the oncologist's part, the palliative care team was not there to talk their patients out of treatment. The palliative care team was there to help their patients feel as well and do as well as possible, and that the result of that is that more people were able to finish treatment because they felt well enough. So it was really about relationship building between the teams and recognizing that both are on the same side of the table and working together to achieve the best outcomes for the patient. And I think that requires some self-knowledge and self-evaluation on the part of both parties.
Thank you, Diane. I think because of time, we're going to close with that question. Just a quick reminder, we have more webinars in an upcoming series. That I will be sharing the slides as well as the recording from this webinar. But most importantly, I wanted to point out that at the end of this session, you will a survey will pop up. Please take a few minutes to answer. We'd love to hear any suggestions you might have moving forward. And we, on behalf of the rest of the organizers here, I'd like to thank you all for participating, and we look forward to having you in the upcoming series. And many thanks to you, Diane, and your team, and it was a pleasure having you all.
Thank you. It was my pleasure.